Welcome. Today I'm going to be talking about dealing with medical ethics. Specifically, this presentation is designed for the pre-hospital care setting. So we're looking at people wanting to become EMTs to run on an ambulance, whether that could be a first responder level, an advanced EMT level, up to a paramedic level. So we're talking about some of the scenarios that we might run into and how we deal with them ethically in the field in the pre-hospital setting. We will relate back to how this affects the healthcare debate a little bit here and there, but really the focus here is talking about medical ethics and how they may have changed from long periods of time ago to how we deal with them in the daily settings. Near the end, or probably the second half of this presentation, there are going to be some scenarios. I will try to pause myself where you have time to reach up to the mouse and hit pause and think about the scenario and then turn it back on, and you'll hear some of my thoughts on each of the scenarios. So that's the plan to talk about dealing with medical ethics. So, ethics, where does it come from? Ethics is based on philosophy. Ethics is basically a branch of philosophy that examines the right and wrong of moral behavior. This includes moral concepts and moral language. So it gives us a way to talk about ethics, and it gives us a language to use in that. And some of that language we are going to talk about today. Things like justice, virtue, duty. We'll talk about autonomy, and so on. To really understand ethics, I'm going to talk real quickly about a little bit of the history and kind of get us to modern day. So in our case, we're looking at, I gave a couple examples. So as you can see on the screen, we have Socrates, Aristotle, Kant, and then I kind of worked my way through some that you may know of or you may not know of. So specifically, let's talk about Socrates to start off. We're talking about one of the founders of Western philosophy. He really started his big piece would be the Socratic method, which is really questioning everything. And in that, we really first developed this idea of critical thinking. And that plays a huge role when we're talking about ethics, because we have to be able to critically think about a scenario or a situation in order to make an ethical decision out of it. From there, we have, moving through time, we ran through Aristotle to name another one. Really the founder of virtue ethics. Which is how one's character and virtues affect their ethical behavior. So really looking at what does it mean to be ethical, and how does it change per person, or why is it different for everybody? Looking at another one a little bit more modern would be Kant. Kant is considered, I believe he was German, was considered to be a modern philosopher, or the father of modern philosophy. Really talked about reason is the source of mortality. Not mortality. Sorry, the word escaped me there for a second. But we'll move on. Sorry. So then we get into really the medicine side. We have Hippocrates. Sorry again. Hippocrates really is the father of Western medicine. Little is really known specifically about him. There's some assumptions made as I kind of looked up a little about Hippocrates. It was kind of interesting how there is really little written about him, or written about his thought. His thoughts weren't really ever written down a lot. He was said to be the creator of the Hippocratic Oath, therefore the title of it, which really is the first idea of medical ethics. From there, not much really big in history was defined as changing medical ethics until we have Percival. Percival was a English doctor and philosopher. in the late 1700s, early 1800s, and he wrote a pamphlet of the code of ethics that should be followed by doctors. Back in around 1794, it was republished in the early 1800s. This document really is the beginning of modern medical ethics. Move it to the United States in around 1847, the American Medical Association, which was around prior to that, they had a meeting in Philadelphia in 1847. One of the big tickets of that meeting, or big discussions in that meeting, was medical ethics. And what they did is they basically took what Percival came up with in that pamphlet back in the early 1800s and put it into American terms, and there is the basis of all of our medical ethics that we follow even today. And that's kind of the beginning of how we got to where we are. That AMA Code of Ethics that was developed in 1847 has been revised about a half dozen times over that, was that 70 years, 60, 70 years. And some of them, a lot of them I didn't really want to talk about, but two that caught my eye as I looked at some of the revisions was in 1980 we had a revision, and it was the first time that the AMA tackled the idea of professional standards versus legal requirements, looking at the way we think about ethically treating patients now and the healthcare systems we have now in the healthcare debate. That really is a hot topic. Those patients that we really don't see the medical need or standard that they need to be transported to the hospital, but on the other side we worry about the legal requirements and legal ramifications of being sued for not taking them to the hospital. That was first looked at in 1980. Another revision that I found interesting was really this, I think it's really the biggest push from the medical field side of medical reform in the United States, and that is in 2001, the AMA came out and said all of our doctors believe that access to medical care should be universal. Not that we should have universal health care, but that we should have access to universal care. Later on I'm going to talk a little bit about the idea of the perception of insurance or medical care over decades or centuries has always really been thought of as a privilege, not a right. And that really has changed over the last 20 or 30 years in the United States, and the AMA really made that big push in 2001. So with that being said, let's look at four major concepts when we talk about the ethics, specifically in the field. What are things we have to think about? So these four we're going to talk about really for the rest of this presentation are beneficence, non-malfeasance, autonomy, and justice. So what are each of those? When we look at beneficence, sorry, my language isn't the greatest, mic's not the greatest, but we'll get through this. It's the obligation to help people in need. As simple as that. The quintessential model of this term is Good Samaritan, that our job is to help people. There's no really other way to talk about that one. So we'll move on. Non-malfeasance. Non-malfeasance is a lovely, I love that negative term at the beginning, but non-malfeasance is the idea that we do no harm. Or medical concept, we talk about first do no harm when we think about treating our patients. We'll talk about that during a bunch of our, one or two of our scenarios in a little bit. Autonomy is a very interesting one. Near the end of my presentation, we're going to talk about what does it mean to be able to make a decision. Does age, mental status, do those affect the idea of being able to give consent, which autonomy is a little bit about. But for now, let's just talk about autonomy itself. Is talking about the patient's right to make a choice. Doesn't mean they have to make a good choice. Patients could decide to do nothing about fatal injuries. And that is their choice. Again, we'll talk a little bit about when we get to overrule their choice, but there's some very specifics to be able to do that. So the fourth piece of when we talk about medical ethics is considering justice. And the idea of justice is talking about treating everyone fairly or in a fair manner. That one is a fairly simple idea, that we should treat the poor like we treat the rich, we should treat the white like we treat the black. Where justice does become a little interesting is when you start talking about the idea of justice in society and allocating limited resources. We'll again come back to that one for a short bit at the very end. That term distributive justice we'll talk a little bit about. But for the next little bit, some scenarios are going to come up in a few minutes. Really think about these terms. Think of them very generically. Don't try to pin yourself in and say, well, is the kid 18 or is he 25? Think of them pretty generically. So beneficence, the idea that we're obligated to help people. Non-malfeasance, the idea we do no harm. Autonomy, that patients have a right to make their own decisions for themselves based on information. And then the last one, justice, that we should treat everyone fairly and equally. So great, now we have some simple ideas of what ethics and some concepts of ethics. And yeah, I tried to give you a little history of ethics. We'll see how that went. But the next piece is, well, how do we make a decision about ethics? So I understand what it means to help people, but how do I know if my choice is ethical? I know what the word means, but there are great ways in resolving ethical conflict. And there's some basic tests that we can ask ourselves or do in order to say, is this choice ethical? These three simple tests. We don't always do all three. We may choose one. We may not realize we even do these. But if you are asking yourself the question of, is this decision I want to make right now ethical? These are three very simple ways to quickly decide, am I making a good ethical decision? Impartiality test is the first I'll talk about. And simply defined, we're talking about, ask you, would you be okay with this? So if I was the patient or my family member was the patient, would I agree with this course of action, this treatment? Is a real great simple way to think about this. Another term people describe this one as is the golden rule. Do unto others as we would want done unto us. Is a great way to look at, is my choice ethical? Great, I would like to take this patient to the hospital. I would like to do it by just picking him up, putting him on the stretcher, and whisking him away. Is that how I would want to be treated? Or would I rather have some other interventions done prior to sweeping me up and putting me into the stretcher? So there's the first one, impartiality test. The next one is the universality test. So in this task, we ask ourselves the question, we ask, is the answer good in all similar circumstances? So we ask ourselves in a scenario that I just said, that we'd pick this patient up, put them on the stretcher, and whisk them away. Would I do the same thing for a patient who appears to be homeless? So I'm at the millionaire's house, and my decision is they fell out of their swing set, and I said, let's just get them to the hospital quickly because they need higher care than I could give. And I pick them up, whisk them away. And I want to say to myself, is that the right choice in this situation? Well, in this test, I'm saying to myself, well, what if this was not in the millionaire's backyard? What if this was a 25-year-old that tripped and fell and had about the same amount of injury? how would I treat them? Would the same treatment be applied? So we try to put it to similar, not exact, but similar circumstances, and we do the same thing. If my crew was set up differently, if the patient's family acted differently, but the injury is the same, would I choose the same thing? If the answer is yes, then our choice is probably ethical. The last one is interpersonal justifiability test. Justifiability test. Oh my goodness. Can you defend or justify your actions? This one is one that rings in back of my head every single day when I'm working on the ambulance. I think to myself as I'm taking the patient to the hospital, can I defend this decision to the doctor I'm handing the patient over to my medical director who is in charge of all medical decisions that I make, to my service chief who is my direct boss, maybe my supervisor for the day. Can I justify my actions in clear, concise ways? A great one that I used to talk to EMT students about, or more advanced EMT students, was back when we used to backboard everyone. We don't so much anymore. New research is telling us that it actually does more harm than good. But what we used to talk about is the idea that if you chose not to backboard somebody, that is perfectly fine. However, you need to have a solid, justifiable reason that you did that, or in this case, didn't do that, and be able to enunciate and describe that to the receiving hospital. Because they want to know. And your answer is ethical, but you need to be able to defend it. So using those three, as well as the previous information, we're looking at those three terms, beneficence, non-malfeasance, autonomy, and justice. We're going to look at some scenarios. And so these scenarios should probably take us maybe another 5 or 10 minutes. We'll see. And we'll go from there. So if you need to take a break, pause, think about these. You want to show them to a friend, have them discuss, and then see if you agree with me. I'm not saying my answers are perfect, but it's just my view thinking about the ethics of these scenarios. And again, don't read too much into the scenarios. They are made to be very vague. For those of you getting ready for the National Registry exams, that is what the National Registry of EMTs loves to do, ask vague questions versus very detailed. Here we go. So case 1. It is 03:30 in the morning, and you are called to the scene of a 32-year-old male with a long history of kidney stones who is probably suffering from another one now. The location is a moderate income neighborhood, and he lives with his wife. They have no children, and they have 2 cars in the driveway. He has been in mild to moderate pain for 3 days. You and the patient both understand the condition is not generally considered life-threatening. He's allergic to the only pain relief medication that you have available, so there is little you can do to help him with his pain. Your partner questions, should we transport this patient? The patient states his wife can drive him. Your partner states his wife could drive him. It would be much quicker for all of us. For those in the pre-hospital field, this is a scenario we hear a lot of, these patients who are kind of sick, kind of not sick, and do we take them to the hospital, do we not? So questions like, think about this 32-year-old at 3:30 in the morning that's had pain for 3 days. I'd like you to think about, what are your thoughts so far? How does beneficence play a role here? What do you say to your partner? And then any other thoughts you might have. So go ahead and pause for a minute and come back and we'll see what I thought. All right. So hopefully you just paused for a few seconds and just came back and thought about this scenario. My general thoughts when it comes to thinking about these kind of settings is I need to understand that patients have a certain amount of resources. Sometimes the resources are physical, cars in the yard, a partner they live with. Sometimes they're psychological, how well they deal with pain, how they've dealt with emotions in the past, and all those play a role in what is a patient. When we think about beneficence playing a role here, we have a patient who we didn't say in the scenario, but let's assume the patient called 911 himself. This patient, by calling 911, is saying that I don't understand or have resources available to deal with this anymore. I know it's been 3 days, I know it's been mild to moderate, but at some point people run out of resources. He ran out at 3:30 in the morning. But our job is not to say to him, suck it up, you've been dealing with it for 3 days, you got a car, drive yourself, have your wife drive you. Our job is to find the best way to get him what he needs. He needs medical care at this point. Does he need to go with us? I'd argue maybe not. Need maybe some more information, but I would be safe by saying this patient doesn't necessarily need to go by ambulance, and but I still need to treat him like a patient. How would I deal with my partner? What do I say to my partner? First, I don't say anything to my partner in front of the patient, but later on, a great conversation about what I just said. Understanding that patients have a certain amount of resources. I had a great example this a few years ago. I had a leg injury that I dealt with from midday till about 3 a.m. And at 4 a.m. I woke my wife up, which we had a 3-month-old and a 3-year-old, and made her drive me to the hospital. I dealt with the pain as much as I could in many ways as I could think of till I couldn't do it anymore. I happen to have the last resource, have my wife drive me versus an ambulance, but that's just the resources I happen to have. So that's how I feel this discussion should go. What are your thoughts? Let me know. Send me emails, send me comments. I would love to hear. So we have another scenario. It's actually the same as the last one. You chose to transport this patient. You're now in your ambulance, beginning your transport to the hospital, and the patient says, can't you use your lights and sirens and get us to the hospital faster? It's a misnomer. We don't use our lights and sirens for everything. For those of you looking at this presentation from the getting into EMS, that isn't what we do. We do not drive like crazy. We don't speed every time we possibly can, especially to the hospital. Maybe to the patient we typically drive lights and sirens because we don't know what we're going to. But going to the hospital is rare I choose to use lights and sirens. We'll talk about why in a minute. What I'd like you to think about is pause and think about again, what would you do, why? How do you do this? How does this apply to non-malfeasance? And what are the potential benefits of using your lights and sirens versus potential harms? So go ahead and pause, and I'll talk to you in a minute. Welcome back, if you paused. So in this case, like I said, I don't believe lights and sirens should be used very often, even on the way to the hospital. We could have a whole other conversation on that. But how does malfeasance apply here? Well, think about the term, do no harm. This is a patient who we all agreed, the patient agreed and the provider agreed, that this is typically non-life threatening. He has mild to moderate pain that's been 3 days long. There is no need to rush this patient to the hospital. Does he need to go and get some assessment, maybe get some pain management, get something to start breaking up the stones? Yeah, but he doesn't need to get there right now. He needs to get there in a little while. So what is the potential benefits of using lights and sirens? Well, the benefits are, you get there a few minutes shorter. I've worked nights most of my career in pre-hospital care, and when it comes to lights and sirens, going in Chittenden County, transport of 10 miles plus or minus, you're talking about 30 seconds to 2 minutes faster. That isn't going to make a big difference in this patient. What are the potential harms? This is a piece that I do in all my EMT classes. We talk a little bit in the advanced classes and the paramedic classes. But when it comes to EMTs, we do talk about the idea of death and dying. And one piece we talk about is how to deal with that. How do we deal with partners that this happens to? EMS is a very dangerous field to be in as a profession. The death rate is pretty high compared to other professions. I believe it's in the top 5, if not definitely the top 10. It might be even close to the top 5. When you look at the reasons EMT providers die, yeah, once in a while we get attacked, once in a while we have heart attacks ourselves when we're on duty, but a vast majority of these deaths happen by vehicle crashes. Number 1 is helicopter crashes, and number 2 is ambulance crashes. Bad things happen when we have our lights and sirens on. We've had this happen in Vermont. When I typically do this lecture for EMTs, I usually Google EMT death or firefighter death, and every single time I do this, I can usually find someplace between 1 and 5 providers died in the past 3 to 6 months. Just by that quick Google search. I'm sure I could find more, and almost always they're related to traffic fatalities. So there's that one. Alrighty, let's move on. Looking at 3, got the 2 more to go, and then 1 slide to end it. So when we talk about this scenario, it is a completely different one, so let's read through. You're on scene with Bob. Bob is a 58-year-old male who's having crushing substernal chest pain that is radiating to his left arm for the past several hours. He also has some shortness of breath with all of this. Condition is unchanged after oxygen and nitro. You could say he had his own at home, we gave it to him, doesn't matter. But after this happens, you talk to Bob. When you tell Bob at which hospital you'll be going to, he emphatically says, I am not going to any hospital. And you probably could change the word, add a word in there when these patients really get emphatic about, I'm not leaving my house. And yes, this does happen once in a while. So what I'd like you to think about again is, what would you do? Why? But specifically, think about the idea of autonomy and how it plays a role here. And then you can also have some side conversations, some side thoughts on, well, what about autonomy versus beneficence? Or what about non-malfeasance versus autonomy? How do those play a role together? But this scenario really like you think mostly about autonomy. So take a break and come back in a minute. Sorry, needed a drink of water. I'm back. So, with this one, what am I thinking? When I talk about autonomy, how it plays a role here, as we said in the definition, patients are able to make decisions that when they have fatal injuries, they could die. They have the right to make that decision. This patient has the right to not go to the hospital. In a minute, or sorry, more like 5 minutes, we're going to talk about consent. But this patient sounds like he knows what's going on. He's chatting with you. And if he does not want to go to the hospital, in the end, he has the right, when we think about ethics and autonomy, the patient has the right to make that decision. What would I do in this scenario? Well, yeah, I'm not going to snatch him up and take him to the hospital. I wouldn't just let him stay. Make a plan, talk to family members. One of my favorite tricks at the very end of the game is get the patient on the phone with the hospital that I want to take him to and have him talk to a doctor. And some of those conversations are pretty entertaining. I'll use the word, you are going to die if you stay home, once in a blue moon. But I have heard on many occasions that's some of the conversations the docs have with these patients. And majority of the time they believe the docs and sure, we'll go to the hospital. But I can't just snatch him up. Based on the idea of autonomy, this patient has a choice. And in this scenario, he chose not to go. And it does become a very long, unfortunate scene sometimes. All right, that gets us to our last scenario. The last scenario is this picture more than a scenario. So you're looking down on, you can see fire truck ambulances. You see lots of providers in yellow jackets. That's where I got cursed. There we go. Yellow jackets are probably providers. Covered in red are patients. You see these colored tarps on the ground. We're talking about a mass casualty incident. Green meaning they're kind of hurt but not really. Yellow means moderately injured, and red is, they're severely injured when we look at MCIs. So for the purpose of this case scenario, this case study, we will assume the incident is a small plane crash into a viewing area at an air show. Therefore, the number of patients. So what you need to think about is, what do you do first? Where do you start? And how does justice relate to a mass casualty incident? Take a quick break. I'll be right back. All right, so you're back. So how does justice play a role in a mass casualty incident? Well, when we talk about justice, we talk about treating everyone fairly. Well, yes and no. The other piece, what we have to think about in a mass casualty idea. Now, if this was Johnny versus Jane, we do treat them equally. They both get the same treatment for bleeding control. We would open their airways the same way. We would ventilate them the same. They'd give them the same medications if they needed them. However, in a mass casualty instance, justice does not mean everyone individually. When we talk about a mass casualty incidents, we really do define them as everybody is really one patient. And we do the greatest good for the greatest number of patients. For those of you who've seen how the medical field at the hospital works, think to the emergency room. And if I have a patient that wheels into the emergency room who's in respiratory arrest, they still have a pulse, but they are not breathing. Think about the people you've seen in those rooms. We're talking about one or two docs who are in charge of probably the emergency room. The one that's in charge of that room, partner may come in because it's a big call. Usually some specialists if you're talking about larger emergency departments, so respiratory might be there, maybe there's trauma there as well. Each of them will have maybe residents with them. There's going to be easily a few nurses doing multiple things, techs. In some cases you have research happening, so you might have someone sitting in the corner. The point being there's lots of people dealing with this patient. Well, when we talk about justice in a mass casualty incident, if I do that same idea in the field for a patient who is very unlikely to survive, I will lose that patient, very likely, and I'm going to lose many, many, many other patients. So when we talk about justice, yes, person to person, we treat them equally. But when we talk about an MCI, things change a whole lot. We still treat everyone, everyone fairly in the same manner. However, we treat everyone as one patient. We will, if you're going to do more stuff with me later on, talk more about MCIs and how they really do change how we think about medicine and how we make our decisions. But it still is the same idea when we talk about justice. We do the greatest good for the greatest number of people. Hi. So that kind of covers some scenarios. To end, I really had these two ideas I did want to get back to. I've hinted towards consent, and I've talked a little bit about distributive justice, MCIs, that last one we just talked about. So let's talk about consent. When we talk about consent, we're really talking about autonomy here, and autonomy can be affected greatly by the consent that patients can give. When we talk about age, that 17-year-old with a minor fender bender at their high school as they're leaving at 3 o'clock in the afternoon, and we show up and the kid's just bummed, he knows his parents are going to be upset with him, and he's not hurt at all, says, you know what, I don't need to go to the hospital. That patient can't give consent. They have no autonomy. They're under the age of 18. Their parents have the right of the autonomy for that child. There are some exceptions to that rule. Women who are pregnant or give birth to a child automatically become emancipated. At least in the state of Vermont, it does change state for state. But in general, people under 18, they actually don't have autonomy. Their families do. Doesn't mean we don't listen to them and consider it in our decisions, but they legally can't use the idea of autonomy. Mental status. So if we have a patient who is high on some kind of a drug or medication, who is drunk, who has a head injury, who is unable to make healthy decisions for themselves, we think about the idea of they're alert and oriented. If they're not alert and oriented, they too are patients who don't have autonomy. Someone else will make medical decisions for them. Another interesting one would be legal status. I kind of covered that one already. The pregnant teenager one would fall underneath there. The last is implied versus informed. Again, we could do a whole 30-40 minute lecture on implied versus informed consent, but the idea is informed consent means I told you what's happening, and then you use your autonomy and make a decision, and I will follow it, assuming all the above stuff works out. Implied consent basically means your autonomy went away because you can't answer questions. You're unresponsive. You are underage. You have poor mental status. And in those cases, I treat you like a normal person would want to be treated in general terms. So if you're unresponsive, have no pulse, and not breathing, we assume most people like staying alive, so therefore implied consent allows me to treat you. So there's our quick run over of consent, which we kind of hinted towards during all this. The last is distributive justice. Distributive justice, we talked about MCR already, but to move things along, we'll talk about the burden to society. That is really that extra piece. We talk about justice being everybody's treated the same. When we talk about distributive justice, we're talking about the idea of allocation of benefits and how the burden to society should be considered in that. One of the interesting ideas, I think I said in the first few minutes of this, is the idea that privilege. That healthcare was always considered a privilege, not a guarantee in the developed world until recent years, in the last 30 years or so. However, now we really think of it as a human right. I would argue that yes, it is a human right, and we should be able to get equal and good health care no matter who and where we are. And this really is one of the biggest pieces of the argument of health care in the United States at this time. How do we define the burden of society? How is it going to work where the poor get insurance equal to the rich and the rich pay for some of the poor? That burden shift is something that really is the biggest struggle when looking at this. I wish I had more time to go into that, but my purpose today was to talk about ethics. I think I did that. If you have any questions, please let me know. I